Hello, this is Eric Strong from the Palo Alto VA and Stanford University, and this is the 20th and final lecture in this course on understanding ABGs. The title of this lecture is Bringing It All Together, using the ABG to create a unified model of human pathophysiology, and that's what I hope to do. The specific learning objectives are first, to become familiar with the measurements of total blood oxygen content, abbreviated CaO2, and oxygen delivery, abbreviated DO2. Second, to have an understanding of how the same knowledge used in analysis of an ABG can also be used to create a unified model of pathophysiology. And finally, to be able to incorporate ABG interpretation into strategies for diagnosing a wide range of pathologic conditions. To create our unified model of pathophysiology, I will first need to explicitly state the fundamental principle of human physiology. This is what all of the preceding 19 lectures have been driving towards. The primary purpose of human physiology is to enable aerobic respiration by delivering oxygen to cells and by removing carbon dioxide from cells. All organ systems and individual biochemical processes exist to support this purpose. For example, most obviously, the purpose of the lungs is to assist with this exchange with our outside environment, and the purpose of the heart is to pump the blood around the body, carrying these gases to and from the lungs. But consider what the purpose of the GI system is. It is to bring in carbohydrates and fats, which can be converted to glucose or other precursors of the Krebs cycle, which will then be ultimately used to drive oxidative phosphorylation. And the primary purpose of the neurologic system, which is to allow people to move around in the world and acquire the food that is then introduced into the GI tract. I'll acknowledge that this is extremely reductionist, but this is what our bodies ultimately do. Whether or not you realized it at the time, I have already reviewed the majority of the biochemical processes and systems which support aerobic metabolism, but there is one or two pieces left before we can fit everything together into a cohesive whole. Those final pieces are the final steps of how oxygen gets from air into our cells. We have already reviewed the process of ventilation, by which oxygen enters the alveoli, and diffusion, where oxygen moves from the alveoli into the pulmonary capillaries. The last lecture covered transport, that is, how oxygen binds to hemoglobin. The remaining steps are how oxygen is delivered to the organs and peripheral tissues, and then how oxygen is extracted by cells at those locations. Let's talk about the oxygen content in blood. This was addressed informally in a couple of lectures already, but let's try to formalize a process by which we assess how much oxygen is contained within a sample of arterial blood. Arterial oxygen content, abbreviated CaO2, is equal to the sum of oxygen bound to hemoglobin and oxygen dissolved in blood. The amount of oxygen bound to hemoglobin is equal to 1.34, which is the maximum oxygen carrying capacity in milliliters of oxygen per gram of hemoglobin, times the hemoglobin concentration, times the oxygen saturation. Although most textbooks use the term SaO2 to describe oxygen sat in this equation, for reasons discussed in the last lecture, I personally prefer this percentage O2 hemoglobin. The oxygen dissolved in blood is equal to 0.003, which is the solubility constant of oxygen, times the partial pressure of oxygen. Let's plug in numbers for a typical healthy adult. 14 grams per deciliter for hemoglobin, an O2 sat of 98%, and a pAO2 of 100 millimeters of mercury. Multiplying these numbers out, we find that in 100 milliliters of blood, about 18.4 milliliters of oxygen is bound to hemoglobin, and 0.3 milliliters of oxygen is dissolved in blood. In other words, the amount dissolved in blood is negligible in most circumstances. Therefore, we can approximate CaO2 as 1.34 times hemoglobin concentration times the oxygen sat. Even though this value is traditionally called the oxygen content, it would be more accurate to call it oxygen concentration. There is a closely related physiologic parameter called oxygen delivery, abbreviated DO2. DO2 is the rate at which oxygen is brought to the peripheral tissues. When discussing the DO2 for the entire body, it is equal to the cardiac output times the oxygen content. Cardiac output is a concept which we have not explicitly discussed during this course, but which is reviewed in my lecture on shock, also available on this channel. Succinctly, cardiac output is the flow of blood from the heart to the body in units of volume per unit time. It is primarily dependent on four things: the heart rate, intravascular volume, sometimes called preload in this context, myocardial contractility, and something called afterload. We can also discuss oxygen delivery on a regional level, in which DO2 is equal to the blood flow to the region of interest, designated Q, times CaO2. In addition to dependence on cardiac output, Q is also dependent upon the presence or absence of maldistribution of blood flow. In an obvious example, if a blood clot embolizes to an artery of the gut, a person could end up with impaired delivery of oxygen to the corresponding segment of gut, despite the body's overall cardiac output being intact. In a less obvious but nonetheless more common example, a patient with septic shock has systemic vasodilation, in which there is low resistance present in blood vessels that travel to non-essential parts of the body, like the extremities and adipose tissue. These low resistance vessels shunt blood away from critical areas like the brain and kidneys, resulting in organ dysfunction and a switching from aerobic respiration to anaerobic respiration, that is, metabolism that does not require oxygen. So now, having briefly covered the concepts of oxygen content and oxygen delivery, let's take all of the information learned throughout the entire course and assemble it into a unified model of pathophysiology. As I stated earlier, the enabling of aerobic respiration is the foundation of physiology, so I'm going to place that in the middle here. And the link to pathophysiology is the balance it has with anaerobic respiration. Around this balance, I'm going to lay out the four fundamental domains of physiologic processes that we are able to directly analyze using the ABG. First is acid-base balance, most fundamentally dependent upon the kidney, and concisely summarized mathematically by the Henderson-Hasselbalch equation. Next is ventilation, which requires communication between central and peripheral chemoreceptors, the respiratory centers of the brain, and the lungs. The process of ventilation is summarized by the alveolar ventilation equation here. Continuing around, there is oxygenation, also dependent on the lungs. There are two fundamental mathematical relationships involved with oxygenation: the alveolar gas equation and the simple formula for determination of the AA gradient. Finally, our last domain is oxygen transport and delivery. These closely related processes are defined by the oxygen hemoglobin dissociation curve, the formula for oxygen content, and that for regional oxygen delivery. This model will feel incomplete if we don't also include two aspects of physiology that have been discussed only in passing and which are not the focus of this course per se. The first is the intravascular volume, that is the body's tank full or empty. The second is the cardiac function. There are many ways to describe cardiac function, but I will choose to summarize it as cardiac output equals stroke volume times heart rate, where the stroke volume is the quantitative measure of the volume of blood ejected from the heart with each contraction. A viewer who is tuning in here halfway through the final lecture in this course on ABGs would likely be surprised to see the cardiovascular system superficially appear to play a much more minor role in physiology compared to the pulmonary and renal systems. However, I want to stress that this model is being created through the lens of ABG analysis. A model created by a cardiologist from the viewpoint of the heart would look quite different. It wouldn't necessarily be better or worse, just an alternative approach to understanding the complex system that is the human body. Let's now take a look at how all these individual pieces are interconnected, starting with acid-base balance, since that's where our course began. Through multiple mechanisms within the kidney, pH feeds back and helps to regulate serum bicarbonate concentration. Bicarb can also be impacted by intravascular volume, most prominently in the case of a contraction alkalosis, where volume depletion leads to concurrent retention of sodium and bicarbonate ion and loss of hydrogen ions. Low pH is sensed by peripheral and central chemoreceptors, which leads to an increase in ventilation by increasing both the respiratory rate and tidal volume, the latter of which is possibly more affected. Ventilation in the form of PaCO2 directly feeds back to the Henderson-Hasselbalch equation. PaCO2 also directly impacts the respiratory rate and to lesser extent tidal volume as yet another means of feedback. Ventilation and oxygenation are linked in two specific ways. First, the PaCO2 is directly inputted into the alveolar gas equation. Second, low pAO2 stimulates ventilation. Continuing our way around the diagram, pAO2 is also the primary determinant of O2 saturation via the oxygen hemoglobin dissociation curve. However, low pH, high PaCO2, and high 2,3-DPG all cause a rightward shift of that curve, which will assist with oxygen unloading in peripheral tissues. Returning to the status of intravascular volume, in addition to directly linking with acid-base balance, the primary effect of volume is actually on determination of stroke volume, which helps to determine the overall cardiac function. The specific relationship between intravascular volume and stroke volume is actually quite complex, as increases in intravascular volume can cause either an increase or decrease in stroke volume, depending upon where you're starting from. The cardiac output, with influence of blood flow distribution, determines perfusion of different organs or regions of the body. Perfusion combined with the oxygen content are the determinants of oxygen delivery. And ultimately, it is oxygen delivery to our cells relative to their oxygen demand that is the principal driving force behind keeping their metabolism aerobic. Another important factor to consider is that extreme derangements in pH will lead to enzyme dysfunction, which can result in anaerobic respiration. And there are two specific and clinically relevant ways in which respiration communicates back to the individual components of the system. First, aerobic respiration directly produces carbon dioxide as a byproduct, which will impact PaCO2. And second, anaerobic respiration results in the production of lactic acid. What are the downstream effects of lactic acid? Lactic acid will, of course, drive down bicarb, which drives down pH, which increases ventilation, which lowers PaCO2, which increases pBigAO2, which increases pAO2, which increases O2 sat, which increases CaO2, which increases DO2, which works to ultimately drive respiration back to the aerobic side. So you can see that everything is quite interconnected. I'm now going to concisely summarize a general approach to complete ABG analysis. While you can start with either the acid-base or the oxygenation component of the ABG, I think it is slightly easier to start with oxygenation. When evaluating oxygenation, first check the AA gradient and then compare it with the normal or expected AA gradient, which is dependent upon primarily age, but also on the amount of supplemental oxygen a patient is receiving. Finally, check the saturation gap, that is, make sure that there is less than a 5% difference between the O2 sat measured by pulse oximetry and the O2 sat calculated from the ABG. Part 2 is to evaluate acid-base status. The first steps here are to check the pH and the PCO2 to determine the first disorder. Next, check the appropriateness of compensation to look for a second disorder. Then check the anion gap. Finally, if the anion gap is elevated, check the delta ratio to look for a second or third disorder. Part 3 is to generate a differential diagnosis for each abnormality of oxygenation and or acid-base balance, acquiring additional information as necessary, such as lactate levels and chest X-ray findings. Lastly, create a final summative diagnosis that links everything from part 3 together, if at all possible. For the remainder of the lecture, I'm going to go through 3 example cases, each of which comes with an ABG. These cases are complicated, and analyzing them will require knowledge from most of the preceding 19 lectures. Then I will map out on the unified model exactly how the various physiologic abnormalities relate to one another schematically. I hope these examples will solidify your understanding of ABG analysis and, more broadly, human pathophysiology. I recommend intermittently pausing the video as the examples are reviewed in order to test your own skills at analyzing the clinical scenarios. Example number 1. A 92-year-old woman is sent to the ER from her nursing home after she developed fever and dyspnea several hours ago. On arrival to the ER, her temperature is 102.6, heart rate is 125, blood pressure 76/48, respiratory rate 30, and O2 sat via pulse ox is 85% on room air. She is in respiratory distress and is incoherent. Her exam is otherwise notable for decreased breath sounds at the right lung base. Her jugular venous pulsations are flat, and her extremities are warm. Here is her ABG. I prefer to start with looking at the oxygenation. The first step with this will be to check the AA gradient. To do this, start with a determination of the alveolar oxygen tension, designated P big AO2, which we can do using the alveolar gas equation. The first term for a patient breathing room air at sea level conveniently reduces to 150, and we plug in 25 for the P little a CO2, and we get a P big AO2 of 119 millimeters of mercury. The gradient will be the difference between this value and measured P little AO2, which is 72. Step 2, estimate the normal or expected AA gradient. The common form of this estimation looks like this, where the normal AA gradient is approximately equal to the patient's age divided by 4 plus 4. And then in lecture 17, I discussed why we need to add this additional term, which accounts for worsening of VQ mismatch as a consequence of supplemental oxygen overcoming adaptive hypoxic vasoconstriction. This extra term will be equal to 0 for a patient on room air, so her gradient here specifically becomes 92 divided by 4 plus 4, which is 27. Comparing 27 to 72, we immediately see that she has an elevated AA gradient hypoxemia. Step 3, check the saturation gap. As we discussed in lecture 19, this is the absolute value of the difference between the O2 sat measured by pulse ox, or SpO2, and the O2 sat calculated by the ABG analyzer, or S_AO2. Here, that gap is 2%. Anything less than 5% is considered normal. Let's move on to discuss her acid-base status. Step 1, her pH is slightly alkalemic. Step 2, her PCO2 is low, so this alkalemia is the consequence of a respiratory alkalosis. Step 3 will be to evaluate her compensation. If you remember way back to lecture 4, I discussed a series of equations and rules of thumb for evaluation of compensation. In the case of an acute respiratory alkalosis, the bicarb should be approximately 2 milliequivalents per liter lower than normal. For each 10 millimeters of mercury, the PCO2 is above normal. In this case, a PCO2 of 25 would predict a bicarb of about 21. And although there is no specific rule about how close the actual bicarb should come to the predicted, I think 17 seems just a tad too far from 21. So I would actually label this to be inappropriate compensation. Since the bicarb is lower than predicted, it suggests the presence of a concurrent metabolic acidosis. This metabolic acidosis is not compensation for the respiratory alkalosis, but is rather a separate primary process. Step 4, check the anion gap. As discussed in lecture 5, this is equal to the sodium minus the sum of chloride and bicarb, and helps to determine the presence of a pathologic unmeasured anion. Here are the relevant electrolytes, and plugging in these numbers, we find an anion gap here of 20. We then need to adjust the anion gap in the presence of hypoalbuminemia using this empirically derived formula. This patient's albumin is 2.5, which results in an adjusted anion gap of 24. Therefore, we now know that the metabolic acidosis identified in step 3 must be an elevated gap metabolic acidosis. Finally, step 5, since the anion gap is elevated, we should check the delta ratio. As discussed in lecture 6, this is equal to the change in anion gap from normal, which we typically say is 12, divided by the change in bicarb from normal, which we typically say is 24. Plugging in our numbers, we get 12 divided by 7, which is 1.7. If you recall from lecture 6, interpretation of the delta ratio requires to have a hypothesis about the likely etiology of acidosis, but most etiologies generate a delta ratio between 1 and 2, with the exception of ketoacidosis. Therefore, this delta ratio of 1.7 is appropriate given that we know for a fact that an elevated metabolic acidosis is present. In other words, there is no third acid-base disorder. At this point, let's come up with a differential diagnosis for each of these various physiologic abnormalities. First up, the elevated AA gradient hypoxemia. Although I presented a basic algorithm for this in lecture 18, in practice, all that will tell us is whether or not there is a shunt contributing to the hypoxemia. To get an actual diagnosis, we just need to use our brain a bit and go back to the history and exam. For this patient, the most prominent feature of the presentation is fever, shortness of breath, and tachypnea. This most clearly suggests pneumonia, but could also be due to a pulmonary embolism and the combination of sepsis and ARDS, along with a dozen other theoretical possibilities. The next step will be to check a chest X-ray, which in this case reveals consolidation of the right middle and right lower lobes, so this is probably due to pneumonia. Next up, the respiratory alkalosis. This one's easy. It's just a hypoxemia because the low PaO2 will in itself stimulate the brain's respiratory centers to breathe faster and deeper than normal. Finally is the elevated anion gap metabolic acidosis. Based on an algorithm presented in lecture 8, start with checking the lactate and ketones. In this, ketones are negative, but lactate is severely elevated at 5.5 millimoles per liter. So what's the etiology of the lactic acidosis? On the most fundamental level, this is asking whether there is systemic hypoperfusion present, regional hypoperfusion, or no hypoperfusion. Given the clinical scenario, including severe hypotension and warm extremities, systemic hypoperfusion seems most likely. When this is combined with sepsis, we can better state the cause of the lactic acidosis as septic shock. Now we're almost at the end of the case. The last step is to give a final summative diagnosis. Here, I'd say the patient has septic shock secondary to healthcare associated pneumonia, since she's from a nursing home, complicated by hypoxemia and the lactic acidosis. Although this is how I would personally summarize her diagnosis, there are many other ways that one could construct this with equal degree of correctness. For example, we could list her final diagnosis as healthcare-associated pneumonia complicated by septic shock. Depending upon your area of practice, this difference may be important for billing or coding, but for conveying useful information, both of these say the exact same thing. How does this woman's pathology map out on our model? I'm going to designate the primary problems with a red box and the secondary problems with a tan box. So her primary problems are an increased AA gradient caused by pneumonia and decreased perfusion caused by sepsis-induced maldistribution of blood flow. Secondary problems are the respiratory alkalosis caused by hypoxemia-induced stimulation of ventilation, a change in the O2 sat as P(a)O2 is the primary determinant, which will subsequently affect CaO2, and finally her lactic acidosis produced by anaerobic respiration will decrease the serum bicarb, which will then lower the pH further. We'll go through the other two cases a little more quickly. Example 2. A 45-year-old man is found unconscious in a park. On arrival to the ER, his temperature is 97.5, heart rate 115, blood pressure 80/48, respiratory rate 6, and O2 sat 75% on room air. He is disheveled and comatose. Aside from his vital sign abnormalities and non-visible JVP, pulmonary and cardiac exams are normal. Extremities are cold and mildly cyanotic. Here is the ABG. I'll start with oxygenation again. Step 1. Check the AA gradient. Plugging in the numbers, the P big AO2 is equal to 63 millimeters of mercury. Therefore, the AA gradient is 63 minus 46, which is 17. Step 2. Estimate the normal AA gradient. We'll use the same equation as last case, which is 45 divided by 4 plus 4, which is 15. 15 is close enough to 17 to say that they are approximately equivalent. Therefore, this patient has a normal AA gradient hypoxemia. Step 3. Check the saturation gap. The absolute value of 75% minus 77% is 2%, which is normal. Next, acid-base status. Step 1, the pH tells us the patient has an acidemia, and in step 2, the high PCO2 tells us that the acidemia is, at least in part, due to a respiratory acidosis. When we evaluate the compensation in step 3, we don't even need to know the specific equation. Since appropriate compensation for respiratory acidosis should result in a higher than normal bicarb, and our bicarb is lower than normal, we know that a primary metabolic acidosis must be present. Step 4. Calculate the anion gap. Here are the patient's electrolytes, which gives us an anion gap of 25. We then see the patient's albumin is 2. As a consequence, our anion gap is adjusted upward to 30. So this patient's metabolic acidosis is an elevated gap acidosis. Step 5, calculate the delta ratio. Plugging in his numbers gives us a ratio of 2.6. 2.6 is elevated irrespective of the etiology of the elevated gap. In other words, the bicarb concentration is not as deranged as it would be expected just from accumulation of an unmeasured anion. Therefore, there must be also a metabolic alkalosis present that is pushing the bicarb higher than it would be otherwise. Differential diagnosis. The normal AA gradient hypoxemia is easy, hypoventilation, which has the same differential as the respiratory acidosis. Among all patients, the most common etiologies of a respiratory acidosis are COPD, asthma, obesity hypoventilation syndrome, and drug intoxication or overdose. Given the clinical scenario, it seems prudent to start with looking for drugs. A urine tox screen is positive for opiates and benzodiazepines, and a serum ethanol level is severely elevated at 350 milligrams per deciliter. That's more than 4 times the legal limit for driving here in California. So the patient has a drug overdose. Don't forget to check for other common drugs and poisonings, the ease of which may depend upon your institution's lab. At our lab, our salicylate and acetaminophen levels are easy and quick, and in this case are both negative. Next is the elevated gap acidosis. From the last case, you know that the first place to start is with lactate and ketones. In this case, lactate is elevated and ketones are positive. So why does this patient have a lactic acidosis? The exam and overall picture suggests systemic hypoperfusion, either from sepsis, hypovolemia, or both. Also, as discussed in Lecture 8, people have a much higher propensity towards lactic acidosis when acutely intoxicated with alcohol. Why does this patient have a ketoacidosis? The major causes of a ketoacidosis are diabetes and alcohol. Just to be sure he doesn't also have the former, we should check a serum glucose, which I'm sure in reality would have been done during his first several minutes in the ER. In this case, glucose is normal at 85 milligrams per deciliter. Therefore, this patient's ketoacidosis is just from alcohol. Finally, the metabolic alkalosis. The differential diagnosis for this depends very strongly on volume status and history. His volume status, as previously stated, seems to be low, and based on the history, a contraction alkalosis from dehydration seems quite plausible, though we couldn't rule out concurrent vomiting as he is currently unable to report this to us. So in summary, the patient has an overdose of alcohol, opiates, and benzodiazepines, resulting in a severe respiratory acidosis and hypoventilation-associated hypoxia. As secondary diagnoses, he has a lactic acidosis secondary to hypoxemia, acute ethanol intake, and hypovolemia, plus or minus septic shock. He also has alcoholic ketoacidosis. And last, he has a metabolic alkalosis, likely secondary to dehydration, plus or minus vomiting. In our model, his primary abnormalities are low respiratory rate from drug overdose, low bicarb from his ketoacidosis, low intravascular volume, and possibly low perfusion secondary to sepsis-induced maldistribution of blood flow. Secondary effects include low stroke volume from the dehydration, production of lactic acid through multiple mechanisms, elevated PaCO2 on account of the low respiratory rate, hypoventilation-associated hypoxemia, and lastly, a contraction alkalosis helping to blunt his low serum bicarb. Our third and final example. A 48-year-old man with AIDS and depression is brought to the ER after he was found unconscious by a friend, surrounded by empty pill bottles. On arrival, he is comatose and cyanotic. Vitals, temp 99.5, heart rate 105, BP 95/45, respiratory rate 30, O2 sat via pulse ox 87% on 10 liters of oxygen via face mask. The remainder of the exam is normal. And here is his ABG on 10 liters of oxygen. Step 1. The AA gradient. In this case, the patient is not on room air, but on 10 liters of oxygen via simple face mask. There is no reliable means to determine his FiO2, but based on published empirical data, we can roughly estimate this as 60%, which is the maximum practical amount of O2 that can be delivered via simple face mask. Plugging in our numbers gives a P big A O2 of 403 and a gradient of 33. To estimate the expected AA gradient, we will actually need to use that extra term at the end of the equation. So we have 48 divided by 4 plus 20, which is 36. 36 is close to 33, so there is not an elevation of the AA gradient. An interesting question is whether the patient is even hypoxemic. The O2 sat via pulse ox suggests he is, but the P little a O2 is extremely high, which means he's not actually hypoxemic. This leads us right to the saturation gap. You may have already noticed this, but with step 3 we see that the saturation gap is elevated at 13%. The reason for this might be obvious, but I'm going to come back to it in a minute. Acid base. Check the pH, it's normal, but that certainly does not mean the patient does not have an acid-base abnormality. Looking at the PCO2 and bicarb, we see that they are both severely decreased. The only explanation is the concurrent respiratory alkalosis and metabolic acidosis. The pH is only normal because by pure chance, the effects on pH of these two disorders perfectly balance. Next, check the anion gap, which here is 15. With the adjustment for his albumin of 2, this becomes 20. So the metabolic acidosis already identified is an elevated gap acidosis. Since the anion gap is elevated, we check the delta ratio, which is calculated to be 0.7. This is too low. In other words, the bicarb is lower than it should be if only acid-base problem is too much unmeasured anion. Therefore, there is also a normal gap metabolic acidosis present. Now, our differential diagnosis. Let's start with the obvious, the saturation gap. The combination of an SaO2 much greater than SpO2 and cyanosis occurring at a relatively modest decrease of SpO2 must be the consequence of methemoglobinemia. There is nothing else that will do this. But if you would still want to confirm it with a methemoglobin level, we can check it here, which is 35%. In other words, 35% of all circulating hemoglobin has had one of its iron ions oxidized from the +2 state to the +3 state. This is almost always a consequence of medication toxicity. Since our patient seems to have taken an overdose, checking his medication list is a good place to start. Looking at his medical chart, we would see that his outpatient med list includes some antiretrovirals, Bactrim for PCP prophylaxis, and aspirin. Guess what? The sulfamethoxazole in Bactrim often abbreviated SMX, has been linked to the rare side effect of methemoglobinemia, which is probably dose dependent and thus much more likely in the setting of an overdose. Unfortunately, there is no commercially available test for sulfamethoxazole levels, so this diagnosis will be, to some extent, presumptive. Next, we have the respiratory alkalosis. Here's a near-complete list of possible etiologies divided into common and uncommon. Since we've just diagnosed a patient with methemoglobinemia, we know that the oxygen content in the blood is poor, triggering hyperventilation, though as recently stated, it isn't technically hypoxemia per se. In addition to the oxygenation issues, we also have aspirin toxicity on the list, and given that aspirin shows up on the patient's medication list, it is obviously prudent to check a salicylate level, which in this case is in the toxic range at 3.5 millimoles per liter. Moving on, we have the elevated anion gap acidosis. Once again, check lactate and ketones. Ketones negative, lactate very elevated at 5.5 millimoles per liter. So why is lactate elevated? Is hypoperfusion systemic, regional, or non-existent? In this case, I think it's impossible to say with certainty whether the problem is systemic impairment of oxygen delivery on account of the methemoglobinemia, or if the problem is poisoning of mitochondria on account of the salicylate toxicity. It's probably a little of both. Finally, there is the normal anion gap acidosis. For this, the first step is to check the creatinine. This patient's creatinine is significantly elevated at 3.5, which is presumably acute, since we are told nothing to suggest he has chronic kidney disease. Acute kidney failure is well described in the setting of both salicylate and Bactrim toxicity. Although all of our pathophysiology is accounted for, given the nature of his situation, it would also be prudent to check for the presence of other drugs, so for example, a urine tox screen and acetaminophen level, just to be sure that we haven't missed anything. So our final diagnoses are, number 1, methemoglobinemia secondary to presumed Bactrim overdose. Number 2, lactic acidosis secondary to aspirin overdose and or methemoglobinemia. Number 3, acute kidney injury secondary to aspirin or Bactrim overdose. And 4, respiratory alkalosis secondary to aspirin overdose and or methemoglobinemia. This list sounds quite cumbersome, so I probably would further synthesize it and instead describe the patient's diagnosis more succinctly as an overdose of aspirin and presumed Bactrim, resulting in methemoglobinemia, lactic acidosis, acute kidney injury, and a primary respiratory alkalosis. Mapping this out, because of the salicylate toxicity, a direct impairment of aerobic respiration is actually a primary problem, along with a derangement of the oxygen-hemoglobin dissociation curve due to the methemoglobinemia, the bicarbonate because of the renal failure, and ventilation due also to the salicylates. Prominent secondary effects include an abnormally low oxyhemoglobin percentage and an excessive production of lactic acid, which further impacts the bicarb. If you're feeling a little lost after these examples, please don't be too alarmed. These are, in fact, among the most complicated ABG-related diagnoses you'll ever need to make in practice. So that's it. That's the end of this lecture on bringing it all together and the end of this course on understanding ABGs. So if you made it through all 8 hours, congratulations. I applaud your enthusiasm for learning, and I hope you found it time well spent. Please feel free to post comments or ask questions, and also check out the other videos on this channel.